We are all set. Amy, take it away.
Thanks, Alyssa. Hello, and welcome to the Hirschberg Foundation for Pancreatic Cancer Research webinar, What You Should Know About Pancreatic Cysts. My name is Amy Reese, and I am the Patient and Family Support Coordinator for the Foundation. First, I'd like to acknowledge and thank all of our wonderful sponsors who help make these presentations possible. We know this is an important topic as we've received so many questions from our participants ahead of time. So we'll do our best to answer all of your questions after the presentation. Today, it's my pleasure to introduce Dr. Muthusamy, Director of Endoscopy at UCLA Health and Professor of Clinical Medicine at David Geffen School of Medicine at UCLA. He is recognized as a leader in advanced endoscopic procedures, as well as his clinical research on new endoscopic technologies for the diagnosis and treatment of digestive disorders. Dr. Muthusamy is a prodigious gastroenterologist working to advance and improve the field of study and has been recognized by Best Doctor since 2011. We had the honor of having him speak at our 11th annual symposium on pancreatic cancer, and we are happy to welcome him back to be a speaker for this webinar series. Dr. Muthusamy, welcome and thank you so much for joining us today.
Great. Thank you so much, Amy. It's a real honor to be here with you and Augie and the team and patients and families today. So I'm going to share my screen. Oh, okay. It looks like it says it's disabled. Can we enable that? Oh, here we go. Great. Okay. I'm going to go back just a little bit here. So can everyone see that, my title slide here? Perfect, okay. So I'm going to talk to you today about what you should know about pancreatic cysts. And I'm going to really highlight the key types of cysts because there are very different types of cysts and they have different levels of risk. Some are totally benign and some carry a not insignificant lifetime risk of developing into either dysplasia, which is precancerous change, or frank cancer. And of course, what we're trying to do with management of this is to try to come up with a way to identify those bad actors early and treat them and reassure patients who have low risk cysts. And we're going to cover how we do that in my talk today. So in the next 45 minutes or so, I'm going to cover the different kinds, first of all, the epidemiology of pancreatic cysts. How common are they? And I think you'll be surprised, as Amy was mentioning, at just how common they are. And we'll then talk about the different kinds of cysts. We'll talk about the guidelines. And some of this, again, this is an adaptation of talk I give to doctors, but from a patient side, you'll at least get a sense of what your doctor is thinking when you go to the office with them. You'll see what they're looking for. Why are they asking me about this or that? And you'll get a sense of what their playbook is in determining how to sort of manage these cysts. And then I'll talk about some, novel techniques in terms of both diagnosing cysts as well as perhaps even some non-surgical treatment options. And we'll talk, finally conclude about what we sort of know about pancreatic cysts today. So pancreatic cysts are really common. We originally thought that maybe only about 1% of patients undergoing a CT or MRI just for any reason of the belly had pancreatic cysts. And then a more recent sort of study in 2010 suggested, no, it's actually twice that, maybe 1 in 40 asymptomatic patients who gets an abdominal MRI has a cyst. And another study sort of corroborated that. And then when there was one study that suggested it might even be higher. So we know that pancreatic cysts are common and we are finding them more. Here's a group of about 6 different studies. And in the box I have here, you can see the percentage of people who had a cyst. And so you can see some studies actually had like 13.5%, a couple even had near 20 and even 37%. We think overall that about 15% of people may eventually have a pancreatic cyst. And however, I do want to make this very clear. Pancreatic cysts are common. And from an individual person, the chance of developing a cancer from a cyst is very low, probably about 1 in 400. So, yes, there is some risk, but the individual person's risk, because they're so common, is generally quite low. And so you shouldn't necessarily develop extreme anxiety about this. It's a common problem. We do have management options, and your overall risk lifetime is still relatively low. Now, we do know that it increases with age. So you see that when you're 40 to 49, it's lower. And then as you move to the right with increasing age, the bars get taller. And so you can see these are 3 different studies. Probably the one in black is the one most widely cited. And it's running at about 13, 14% of 70-year-olds will have a pancreatic cyst. So we just finished a big exhaustive review of every MRI that was done at UCLA in 2018 of the belly. And I think we have some updated numbers from the 2010 study. And you can see at UCLA, the numbers are much higher than what was reported. So if you take a look at UCLA, if you're an 80-year-old who came in and got an MRI in 2018, it was basically 50-50 if you'd have a cyst or not. Okay. And that's a huge number. Okay. So look at the 70-year-olds, about a third, 60-year-olds, about a quarter. Okay. So as we increasingly at some point will get an abdominal scan, it is very likely that we will find that we have one or more pancreatic cysts. And many of these cysts are completely incidental and asymptomatic, yet we still have to figure out a way to manage them because there is a small potential that they could become troublesome. And you can see based on size here, overall, we had about 22% of people in the cohort had a cyst. 14% of that 22, or about 2/3, had cysts that were less than 10 millimeters. Okay, so less than half an inch, 4/10 of an inch. Most of the rest had them an inch or less, and very few had these larger cysts. Okay, so most of these cysts are rather small. What's the risk of these different cysts? Well, if you take all comers, as I said, it may be around 15% for a lifetime risk. IPMNs are a little bit higher, 25%. MCNs, which is, I'm going to get to all this in a minute, are 15%. And then there are some benign cysts or that are considered benign that have essentially no malignant potential or extremely low, like serocystic lesions. Now, remember, these numbers are for people who actually got a surgery. Okay, so obviously, if somebody's taken you to surgery, they obviously are worried about some characteristics of the cyst. And we know the vast majority of people who have pancreatic cysts will never sniff an OR. They're not going to have surgery. So these are the numbers of cancers that were found in people who got surgery, not your individual chance. So it's very important to remember that. So the other way you could look at this is there's a whole bunch of people here who got surgery who didn't have cancer. Okay. And that's part of our challenge is we'd love to take everyone who needs a surgery to surgery, but we also likewise want to avoid unnecessary surgeries. Okay. Because you don't want to necessarily go through a surgery if you didn't have to. Again, if you're asking, so this is what I tell people in the office. If you said, "What doctor, I have a pancreatic cyst. What's my chance of getting cancer?" I'm going to tell you 1 in 400. If I find out or if I think that you have this mucinous type of cyst, I may tell you 1 in 125. So again, these are generally favorable numbers. But remember, I just told you that nearly 50% of 80-year-olds have it. So when you have a large number of people with something that occurs rarely, you'll still get some cases because obviously it's so many people, it's such a common issue, right? And that's the issue we're dealing with. So if we get it, one of the questions that had sort of come through in the pre was what are the treatment options? And they're traditionally surgical. So if we think you need a surgery, depending on where your cyst is, if it's in the head or the uncinate, which is more the right side of the pancreas, and some neck cysts, which are here, will tend to take the right side of the pancreas through a procedure called a pancreatic duodenectomy, commonly called a Whipple. And then this is kind of the part in gray is what they take out, and then the redone plumbing is what you're left with. Okay. Now, if it's on the left side of the pancreas, in sort of the neck, the body, or the tail, the part here in gray is what's removed. Usually the spleen is taken with it, and then you're left with the pancreas on the right side, the head and the neck and part of the uncinate. And that's what a distal pancreatectomy is. Rarely there's a part where they can remove the middle part of the pancreas called a middle pancreatectomy, but that's not done very often. But we have to remember that treating this with surgery is not without risk. You might say, well, gee, why don't you just operate and take care of it? First of all, the mortality rate from surgery, all comers, not necessarily at expert centers like UCLA, is about 2%. And, if you talk about, hey, what's the chance I'm going to have a side effect, a problem, maybe some short or medium term complication, that's as high as 30%. So you don't want to rush into surgery unless you really feel like you need it. And I think that's something we need to be very mindful of. The other issue is that the 5-year survival after a cyst resection in patients with cancer is approximately 35%. And that's due to a variety of reasons. Some of it is recovery from the surgery. Some of it is that, patients who get these surgeries usually are older to start with. And some of it means that there could be issues with regards to the cyst coming somewhere else or the cancer recurring, those sorts of things. As I mentioned earlier, part of our problem is that we still have around 2 in 5 people who get surgery who not only don't have cancer, they don't even have high-grade dysplasia, which is kind of the step just before cancer. And so one would argue that maybe we could have waited or avoided surgery altogether in these patients. And for patients who do get surgery, if you have certain kinds of cysts, you don't need any follow-up. But if you have the IPMN type of cyst, even if you cut it out, we still have to watch you because you could develop new cysts in the remaining pancreas. And studies show that people who have cysts, especially the IPMN type, which I'm gonna explain the cyst types, do have an increased risk for just solid pancreas cancer as well. And so they may need some observation for that. Okay, so that's a little bit about how common an issue this is. And I certainly, almost any doctor who, orders scans is going to have to deal with a pancreas cyst because, as I told you, but once you get to age 50 at UCLA, it's almost between a quarter and half per decade that may have it. Okay. So now I'm going to switch now to talking about the types of cysts that are there. Okay. And so we'll start on the left, which are kind of the most benign. And as we move to the right, they get more worrisome. So the benign cysts are what we call non-neoplastic. They're either inflammation, like a pseudocyst you get after pancreatitis. Some are true cysts or retention cysts or lymphadenopathy. These cysts have, if we knew that they were this kind of cyst, no follow-up is needed. We would just tell you, don't worry, have a good life. No issue to do with this, okay? Then there are what we call the neoplastic cysts. These are cysts that tend to have a proliferation of cells. Serocystic neoplasms are generally benign, as I mentioned, and if we know that it's a serocystic lesion, we usually don't follow it. Occasionally we have to operate, but only because this benign lesion gets so big that it causes compression or symptoms just from its size, not because it's necessarily we're worried about cancer. The next group is the one that we're going to spend most of our time today talking about, the mucinous cysts, of which there are 3 sort of types. Well, there's 2 main mucinous types. There's a mucinous cystic neoplasm, or MCN, and then there's something called an IPMN, intraductal papillary mucinous neoplasm. And then there's another one that affects it's a neoplastic cyst. It's not really mucinous, but it affects young women, called a SPEN, solid pseudopapillary epithelial neoplasm. And then finally, there are actually solid lesions that have just liquefied. And so they look like cysts, but they're really just solid. And these are things like solid pancreas cancer, something called an acinar cell cancer, or neuroendocrine tumors of the pancreas. And so these are traditionally solid lesions that almost have liquefied. It's almost like a jelly-filled donut. They have sort of an outside that's solid, but the middle part liquefies. They may have a thickened rim, okay? And of course, these are with increasing malignant potential as you go from left to right, okay? So I will tell you, and our goal is to distinguish mucinous from non-mucinous cysts. Now, patients may find it interesting that even though that I just told you that pancreas cysts are seen in nearly half of people who are age 80, I did my GI training from 1998 to 2001. And I can tell you right now that all of you have probably received just about the same amount of education about pancreas cysts as I did in my 3-year fellowship in the last 12 minutes, okay? Because we really didn't know much about this. In fact, the whole term IPMN only was coined in 1996. So part of a lot of the reason we don't know exactly what to tell you sometimes is because we've really only recently come to an understanding. This is not something we've followed or understood for hundreds of years. It's really been in the last quarter century that we've dealt with this. And obviously, as we've increased the frequency in which abdominal imaging is done, we encounter this more. You were much less likely to get a CAT scan in the 80s as you are today, for example, where it's almost part of the physical exam, it seems like. Okay, with that background, let's talk a little bit about the cast of characters, okay? And so I'm going to go over this at a very high level, okay? So this is called a serous cystic neoplasm, okay, or serous cystadenoma. And these are often in women, but not always, 3/4. They're more often on the left side of the pancreas than the right. And basically, if you can prove it's one of these, you can exhale because these are basically benign. We don't really even follow these. And the only reason we would ever operate is if it grow. Just, benign things can grow too. And if it ever grew to a point where it was pressing on something or you felt it or it was blocking something, then you would do it. But it doesn't really turn into cancer except in rare cases, which don't justify removing it for that reason. So here's an example. They often look like a honeycomb. I don't know if you can see it, but you almost looks like this is a star or a man or woman running here. You can see kind of a septa, and kind of a scar in the middle. And that's a very characteristic appearance. So that's highly suggestive of one of these kinds of cysts. Now, the next one is this MCN, which I told you carries about a 15% lifetime risk of cancer. So that still means 5 and 6 people are not going to get cancer with this. Usually it's one big pocket or a couple of small pockets. And interestingly, it's lined with lining that's very similar to the ovary. This is almost always in women. I can literally think in 20 years of 5 or 6 people that I've seen who were men with this. And again, the malignant potential is over time. So in any given year, it's relatively low. So when I say 15%, it's over the course of the rest of your life, okay? And so here's a classic example. This is looking from the foot down. There's the spine, the left kidney, the spleen, and this is the pancreas tail. And you see this black circle, no lines running through it like the last one. It's just one big pocket. And if this was in a woman, this is very likely to be an MCN, okay? Now, the most common one by far is the IPMN, which is got 3 variants. It can involve just the main duct, it can involve the little side branches, or it could do both, okay? This tends to overall tend to be roughly equal among the genders. Usually, again, older people, that's the trend. It's more often seen in the head than in the body of the tail. So more on the right side than on the left side, but honestly, you can see them everywhere, but it is slightly more to the right. There's different cell types which predict prognosis a little bit. I'm not going to get too much into that. But the main thing you need to know is, think of it as a river and its tributaries. If the main river or the main pancreatic duct is big, there's a much higher chance of cancer, like 40%. And we always basically recommend removing those. If it's the side branch or the little tributaries, the chance of cancer is lower, maybe 10 to 25%. Most people think it's actually not as high as 25, more like the 10. And we tend to watch those. Those are the ones that most of you who may be told you have a cyst likely are felt to have. And then sometimes the main river is dilated and the tributaries have little cysts, and those are so mixed type. But if the main river is dilated, we usually recommend surgery. Okay, so the mixed type are pretty much like the main type. Okay. Here's an example. Again, here's the pancreas duct, and I'm going to show you a normal pancreas duct in a minute, but I just trust me in that this is very dilated, okay? And so this main duct is dilated in particular in this area here, and this is something that we would traditionally recommend removal for. Now, here's a normal pancreas duct. Look how much thinner this one is. But instead, this river is rather thin, but now you have this lake off to the side. This is what we call a side branch IPMN, and these are MRI images. Here's one that looks like some popcorn off the side. These are a bunch of small lakes here, okay? And the main duct is normal. This is what we call a multifocal. And then, of course, there's this kind of biggest lake over here. A lot of people sometimes say, well, doctor, if I have 4 cysts, isn't that a lot worse than having 1 cyst? And the short answer is no, it's not. And in fact, there's some, sort of ironic or sort of counterintuitive that if you actually have more cysts, not only is your risk may not be any more, but it may actually be less. Okay, that's not 100% worked out, but the short answer I want to say is that it's not the number of cysts you have, it's really the size of the cyst and certain characteristics, which I'll get to. Here's a mixed type where you've got the side lake as well as the main river is dilated, and again, this is one we'd recommend surgery for. And then this is the one that I mentioned that's usually in young women. It's not really mucinous. It actually has only a small malignant potential, but usually the people who have this are in their 20s and 30s. And so we're usually not going to leave them with a 50-year lifetime of uncertainty. We usually just remove them, okay? Even though they're generally sort of low risk. And the most common here's one of these cysts, they often tend to bleed within them. And in my experience, most of the women that I've diagnosed with this have usually come in after some kind of trauma where they bled into their cyst. I remember one player was an athlete in high school who had a soccer ball hit her right in the belly, and so she had a lot of pain after that, and it was kind of more than they expected. And then they got the scan and we diagnosed it. Another person was in a motor vehicle accident and the seatbelt triggered the bleeding, and then they ended up, getting evaluated for that. So okay, so that's a little bit about the background of these cysts. And now I'm going to transition in the last 15 to 20 minutes about how we manage them, okay? And so I put a big question mark here because the short answer is we don't exactly know, but we have some ideas, okay? Now, in football, there's an old line that says, well, if you have 2 quarterbacks, you have none. And this is a little bit like that, where if you have this many guidelines, it's because nobody knows exactly what to tell you. But the Japanese first started with these guidelines back in 2006. They revised them again in 2012. Then the Europeans in 2013 came up with an expert statement. The American Gastroenterology Association, which is one of our 3 main societies, came out with one in 2015. I happened to write the guideline for the ASGE in 2016, talking about when you should get an EUS. In 2018, the American College wrote a guideline, and then the Europeans wrote a more formal guideline. Why do I tell you all this? Because depending on which different guideline your doctor tends to want to follow, they may make slightly different recommendations. And so if you see different doctors, they may make slightly different recommendations based on which guideline they choose to follow. Okay. At the end of the day, though, what are we all trying to do? We're trying to make sure that we don't miss any cancers, but we also don't want to do unnecessary operations. And that's what all of these guidelines are trying to balance, is that fine line between, overcalling and undercalling. Okay. And we're trying to, as like I told you, we really didn't know much about pancreatic cysts until the last 25 years. And so we're learning. And as you'll see in most things in life, when you first don't understand something, it seems very scary. Everyone's worried. You probably overreact a little bit. And then as you start understanding it, as you start getting science, you start knowing more, people become a little bit more comfortable. They're more agreeable to a watch and wait strategy. And that's exactly what's happened with pancreatic cysts, okay? So it's important for you to know the three things that we're always looking for when we look at your scan is there a solid component to your cyst? Is your pancreas duct, the river that I talked about, dilated? Because I just told you a dilated river means surgery. And how big is your cyst? And in particular, we're interested in cysts that are more than 30 millimeters, okay? Those are the three things we're looking for. Now, in 2006, if you were a patient and you came to me, this is what I would have done. If you had a less than a centimeter cyst, I would have said, I'll see you back in a year for another scan, usually an MRI. I would have taken you for this endoscopic ultrasound procedure that I do, where I put a camera down your mouth into your stomach, and the camera has an ultrasound built in it. And we look through the back wall of your stomach at the entire pancreas, and I would assess the cyst and possibly stick a needle to get some fluid and analyze it. And if your cyst was more than 3 centimeters, or we saw a nodule in the cyst, or if your duct was dilated, we would just say surgery. And pretty much at that time, all 30 millimeter cysts went to surgery. Well, how did that work out? Well, the good news was we pretty much caught all the cancer, so that was good. But the bad news was that most of the time, the patients we took to surgery didn't have cancer. In fact, if you take a look at these studies, only about 1 in 5 to 1 in 7 patients that got operated on actually had a cancer. So here we were probably taking too many people to surgery. And so the good part was we weren't missing any cancers, but boy, we were sure operating on a bunch of people who probably could have waited or even avoided it altogether. So in 2012, they realized, yeah, we're probably operating too much. So they said, we're going to change these criteria so we don't have to operate as much and we'll watch more people. And so they said, well, we're not going to take every 30 millimeter cyst to the operating room. We're going to make the river look a little bit bigger before we take them. And we're going to create a third category of, we're going to have a high risk, kind of a worrisome feature, which is kind of like an intermediate risk. And so they changed the criteria a little bit, and I'm not going to bore you with these details, but they basically just reset the thermostat to sort of predict who's going to go to surgery. Okay. So now only the very dilated, more than 10 millimeters, got surgery, whereas the intermediately dilated ducts, 5 to 9 millimeters, were just worrisome features. So what they now said was, if you have the high risk feature, you still get to go to surgery right away. But if you have these worrisome features, which are listed here, they said, and again, you ask, what are we looking for as doctors? We're looking for how many of these you have. It's almost like keeping a little score chart, okay? And if you have these worrisome features, we were going to take you for an EUS, okay? And so this is what the 2012 guidelines said. So the new way of handling this now is, if you have a worrisome feature, you're going to go to EUS. If you still have one of those high-risk features, surgery. And if you have none of those things, no EUS, no surgery, surveillance, okay? We just watch you with an MRI in a year. So when we did this, we started missing more cancers, but the positive predictive value, which means that the likelihood when we took you to the operating room that you actually had something, went up. And this is always the trade-off, right? So you can send everybody and miss nothing. You can send fewer and you might miss a few, okay? And where that fine line is what we're always trying to tweak, okay? So again, I'm not going to go through this. I just want to show you, though, this is the guideline your doctors are using. I mean, many people may even have this hanging on the wall in their office. They're looking, do you have a high-risk feature? If yes, operate. No high-risk feature, but do you have a worrisome feature? Yes, then do an ultrasound. If you have neither, they'll tell you to follow up with some kind of an imaging test, and the bigger your cyst, the more often you'll do it. Okay, and that's really the main thing I want you to take away from this big diagram. But this is the algorithm that still is probably one of the two most commonly used in the United States. Okay, so I've been talking about EUS, and that's the procedure I mentioned where we put the ultrasound processor on the end of an endoscope. We pass it down your mouth. We look through the back wall of your stomach. We get beautiful pictures of your pancreas here, and we can even put a needle into your pancreas cyst and sample the fluid and material. Okay. And we can use this to determine what kind of cyst you may have, although the imaging alone is not going to be enough to make the call every time. So is EUS foolproof? Absolutely not, okay? We don't need to do EUS for very small cysts. I just told you most cysts are less than 10 millimeters. We don't really need it for that. If you've recently had inflammation of your pancreas, like pancreatitis, we don't need to do that. If you're not going to do anything with the information, why put yourself through the risk of the test? So if you're not a good candidate for surgery, and if the imaging findings are classic, like I mentioned, you may not need to do any of this either. So what do we do when we do an EUS? Well, we put the needle into the cyst. We send some fluid for a variety of markers, one which tells us whether it's mucinous or not, one whether it tells us whether it connects to the pancreas duct or not. Occasionally, we can send DNA and molecular markers, but to be honest, those have not been as helpful as we thought, and in many cases, they're not covered by insurance. Um, Generally, this is safe, but occasionally you could get an infection, rarely bleeding, and sometimes you can get pancreatitis, inflammation of the pancreas. But the overall risk of this is less than 1 in 20, even if you add up all the risks together. I won't go over this very much, but basically part of the problem is it's very hard to figure out what's a positive on this fluid because there's such a broad array of results. But in general, your doctors are trying to figure out if the CEA is high or if it's low. And in particular, we know mucinous cysts have a higher CEA and non-mucinous cysts, which are more benign, have a low CEA. And so we tend to use the cutoff of 192. So if you get a lab report and say, well, I had this number, your doctor is looking at where it fits. Now, I will tell you, there's some crossover. It's really very useful. If your CEA is less than 5, it's probably not mucinous. If it's more than 400, it's probably mucinous. But could you have a mucinous cyst with a CEA of 160? Absolutely. So again, all of these tests are helpful, but they're not necessarily perfect. Okay, so the CEA is not enough to tell you everything. We can use the combination of the material that we get, how it looks, how thick it is, what the CA and amylase is to help figure out which type of cyst it is. You don't need to worry about that, but I'm just here to show you that that's what we use the fluid for. And, there's different ideas of what the perfect cutoff is. We did a study here at UCLA with a bunch of other centers, and we said, you know what, we don't think it's 192. We think it's actually 105. We actually found the best number was at 105. So again, there's a lot of variability in this, but the higher it is on either or the lower it is, the more confident that we are that it either is or isn't mucinous. Lots of people have looked at molecular analysis of cyst fluid. It turns out that it's a bit of a mixed bag. If your doctors are really unsure, sometimes they can run it on the fluid that we get, but I personally have not found it all that helpful. Some people have used how much sugar is in the cyst. Low sugar seems to be associated with mucinous cysts, and this is a study that showed that it may be as useful as the CEA marker. So that's another test that we sometimes send for now when we do these aspirations. So in short, EUS can help you with pictures. It can help you distinguish to some degree the thing we care about, which is mucinous versus not mucinous. And you could perhaps use molecular analysis and DNA and glucose when you're having still some uncertainty to break some ties, although I don't think that they are used all the time. There's another GI procedure we do called ERCP, but I don't think that it plays a very big role for this. Occasionally in main duct involvement, we can put a video camera up your pancreas duct and help the surgeons decide how much pancreas to remove, because we can say at what point in the river does the wall turn normal. And so that can help them predict how much pancreas to take, and importantly, how much to leave, because of course, if you take too much pancreas, you can develop diabetes. This is the guideline that talked about when you should do EUS, and I was the lead author on that. And again, I've mostly told you what those criteria are. Usually for people with a large cyst or a nodule or one of these main ducts. And we can take biopsies to get more information and also sometimes prove if there's a small cancer there if we find something. Okay. The last guideline I'm going to discuss before moving on and closing with some new things is the AGA guideline. This is the other major guideline that's likely used in the United States. And this is actually probably the one we most closely follow at UCLA, although we do make a slight variant from this as well. So again, we're looking if the cyst is more than 30 millimeters, is the duct dilated, or is there a solid component? Those are always the three things we worry about. Again, the solid component is the most important. The AGA guidelines say that if you don't have any symptoms and you don't have any of these things, you can basically get an MRI kind of every year for 2 years, and then every other year for a few years. And then by 5 years, if it's stable, you can stop. That shocked a lot of doctors when they came out with that, because that's saying that if a 50-year-old gets followed for 5 years and nothing happens, you tell them you're good for the rest of their life. Most people are a little bit uncomfortable with that. So we tend to still follow them, but less often. Here, they required you to have a couple of these features to get an ultrasound, which means it's harder to get an ultrasound in the AGA guideline than the Japanese guideline. And then we tend to go to surgery for those where we confirm the findings on imaging on the ultrasound. So the purpose of the AGA guideline was to drive more people away from EUS and towards getting MRI, because the feeling was we were doing too many invasive procedures that really didn't help us add much extra information. And to some degree, that's probably true. Although one could argue that the AGA guidelines may have swung the pendulum too far in the other direction. And I'll tell you about some new roles for EUS in a moment. Okay, so basically the AGA guidelines said if you have two features or if you find abnormal cells, go to surgery. All right, and I'm gonna go from there. I'm gonna slide forward here. Now, and I've kind of covered this already. Now, the Fukuoka guidelines have been revised further, and if you compare the AGA guidelines, the sensitivity is actually not bad. It's better than the revised Fukuoka. The specificity is about the same. And because of the way these perform, that's why the AGA guidelines are what a lot of institutions in the US do now. There's yet another guideline, which I'm not getting into, but some hospitals use this. This is from the American College of Gastroenterology. Again, you can see it's similar. Again, these are the complicated diagrams your doctors are kind of plugging your information into to make their recommendations. And so this is what your doctors are looking for, many of the same things that I've talked about. And then based on what they find and how big your cysts are, this will tell you how often they follow you, when they decide to order an ultrasound, all these sorts of things, okay? So just making you aware of this, we certainly aren't expected to understand this. So I'll close by talking about what can we do better, all right? And in ultrasound, one of the things that we are trying to do is something called contrast enhancement, which helps us better. I just told you the most important thing is there a solid part to the cyst? And so here you see a little bump here. Is that a solid part? Is it some debris? Is it some mucin like you see in certain cysts? And so if you do contrast enhancement, true solid cysts will have blood flow to them as this one does. So this is a true solid cyst. Here's one that looks like a little debris but doesn't light up. This is a bit of mucin. It's not real, it's false. And so using this, they were able to get an accuracy of around 92%, which is better than what we normally get just with imaging. There's some little probes that can be put through the needles that we put in the cyst that can actually serve as a microscope. And they can actually show us the cells like we were looking at a microscope in real time while we're in your body. And you can interpret it like you were getting a biopsy, but you're doing it actually while the cells are still living. So very cool technology. It's expensive and a little bit finicky. We were initially trying to use it to sort of help rule out the benign lesions. But then a couple of years ago, we sort of pioneered a different approach at UCLA, which I'll talk about. We now have the ability to get tissue, just like when you get a colonoscopy, your doctor takes a polyp and they just grab the tissue. Why can't you do that in the pancreas cyst? Well, for years we couldn't, but now we actually have a needle that we can put a biopsy forceps through and actually sample the cyst wall. And that actually seems to provide an answer in about 2/3 of patients, which is much better than what we've been able to do with other things. There is some risk associated with it, but it does seem to have some value. And so many institutions are doing this. We are actually doing something different where we actually take an ultrasound guided biopsy needle directly and sample the tissue. And we've been able to get an answer in about 5 out of 6 patients. And in particular, we've been able to tell a lot of people who were about to go to surgery that they didn't need to go to surgery because they had a benign lesion, which was very rewarding. Let me give you some examples. This is a 28-year-old female who came to us from Las Vegas because she had a cyst found just when she had a urinary infection. She was feeling fine now. She had no family history of anything with the pancreas. She had an EUS in Las Vegas that showed about a 1-inch cyst. The CEA seemed to be relatively low, which is favorable, but they didn't have enough fluid for DNA analysis. And she came to me because she wanted another opinion. And in part, she wanted to do another DNA analysis. In fact, she told me that if I couldn't prove to her what this was, she was just going to remove it because she didn't want to have a child with her husband without knowing. She didn't want this cloud over her head. So here's her cyst. And what I ended up doing was I put a needle into it and I started sucking the fluid down. And after we sort of drained it, we took the needle and we ran it across the walls. And lo and behold, we were able to prove this was a serous cystadenoma, which is an entirely benign cyst. And so we were able to reassure her enough that she avoided the surgery and she went on. In fact, she sent me a couple of years later a picture of her new baby. So she was very grateful, and frankly, we probably saved her a surgery. Here's another patient with a cyst that was actually read as a mass and was scheduled for surgery, but I was asked to biopsy and I proved it was a benign lesion. Here's another cyst that they weren't sure what type it was, and I biopsied it and I proved it was a low-grade IPMN. So I told her I not only knew what type of cyst it was, but also had some prediction about how aggressive or not it would be. Finally, we are now starting to treat some cysts in a research protocol using a combination of alcohol and chemotherapy agents. And you can see that we can get rid of the cysts somewhere between 1/3 and 2/3 of the time. Although I will say very clearly, this is not ready for prime time. And if you're going to do this, this should be done in a research setting. And even if you get rid of these cysts, you may still need long-term screening because we know people who form certain types of cysts are at risk for solid pancreas cancer too. Here's a Korean study that looked at this and showed that they were able to get rid of their cysts in about 3 and 4 patients. And the new study now suggests that we maybe don't need the alcohol. We just need to shoot the chemotherapy agent in. And they found that when they did that, there were no complications in the group that didn't receive the alcohol, but the results were roughly the same, about 2/3 of the cysts eradicated. So in take home, cysts are common. They're increasingly diagnosed on imaging, as I've shown you. They exhibit variable behavior, but we're trying to figure out as physicians, do you have a mucinous cyst or a non-mucinous cyst? The clinical and imaging characteristics that we get on CT and even EUS are unreliable. Fluid analysis from EUS can help you with the cyst, but it's still imprecise. And we're coming up with new ways to diagnose that are better. And perhaps EUS will be used more often when we can show that we can make a definitive diagnosis on a lot of these cysts. In summary, we've probably been over-aggressive in removing pancreas cysts and in even performing EUS. We need to provide more reassurance to both doctors and you, our patients, that these are still relatively low risk. The risk of a cyst is probably not much different than a colon polyp. We cannot rely on guidelines alone. We need to obviously individualize these guidelines to our individual patients. And hopefully new biomarkers and ability to get this tissue will allow us to sort of stratify patients better. And hopefully we'll have a non-surgical option to treat some of these cysts for you soon. So that's what I wanted to talk about today. And I'd be glad to sort of take some questions in the time we have.
Dr. Muthusamy, excellent presentation. Thank you so much. And I know you received a lot of our pre-questions from registration ahead of time and answered them throughout your presentation. Let me address some of those that are more specific to the individuals, and then hopefully we'll get to the chat as well for questions. Carla asks, this is her question. She's a 69-year-old woman diagnosed with 1.5 centimeter cyst on the head of her pancreas. She noticed that was noticed a year ago when she had surgery, but it wasn't brought to her attention at the time. Recent MRI shows a dilated pancreatic duct with a probable IPMN. Gastro doctor is telling her she should have it monitored with MRI every year, but she has a family history, father having pancreatic cancer at 78 years old. So the question, given all this, do you think I should have an endoscopic ultrasound too, or just monitor this once a year with MRI?
Yeah, great question. I mean, I think the key question, as you probably saw from some of my slides, is how dilated is dilated. And so, if you're sometimes the radiologists, just so you folks know, the usual rule is 4-3-2-1. You can think of the pancreas. I keep using it like a river. So at the upstream part of the river, the left side, it should be about 1 millimeter, and at the downstream on the right side, it's about 4 millimeters. Okay, and so that's what we judge, and as you saw, it has to be 5 or 6 for it to be dilated. And so sometimes I just did a case yesterday for somebody with a dilated pancreas duct, but it never really got more than 4.5. It didn't even meet criteria for this. So the first question I'd ask is the duct dilated? How dilated is it? If it was dilated more than 5 millimeters to maybe 5 to 6, the cyst is still pretty small. I probably still, even with the family history, unless there's more than one family member, I probably still would hold on the EUS. If there was a stronger family history or if the duct was larger, you could do it. But the short answer is it's a complex question. Need a little bit more information, but I think that what they're saying is not unreasonable to do it with an MRI.
And Carla mentioned in the chat the dilation is 5 millimeters.
Okay, yeah, that's right on with technically that's only one. I probably, if you had seen me at UCLA, I would have been comfortable. I would have probably said get an MRI in a year. If you had abdominal symptoms where, we might want to check for symptoms, but if you feel great, I think a year MRI would be okay.
Great. And Lisa had asked, she has a pancreatic cyst and always wondered if one day it will become pancreatic cancer. And I just finished a bout with non-Hodgkin lymphoma on my duodenum. Are they connected?
Interesting. That's a very rare tumor, actually, a non-Hodgkin's in the duodenum. Probably not. Pancreas cysts are very common, and you should, certainly whenever we hear the word pancreas and we think about pancreatic adenocarcinoma, we obviously, all of us as physicians and advocates take that seriously. But I think we do. Hopefully, my talk gave everyone a little bit of comfort knowing that the odds and the numbers are in their favor when it comes to pancreas cysts. And it's really these high-risk criteria that we're looking for.
Great. Diane writes, I have many IPMNs diagnosed 10 years ago. I'm being observed and have a high family risk. No BRCA, 1 or 2. IPMNs are growing. Any treatment to prevent IPMNs from becoming cancer?
Yeah, we don't know of anything like you could take pharmacologically, like, hey, could I take an aspirin, or is there a vitamin, or is there some diet that I can take? There isn't really anything like that at this point to our knowledge. As I said, we're rapidly ramping up our knowledge from something we really didn't even know about till about 25 years ago. The short answer is no. At this point, we simply follow them. We know the math is on our side. In those that seem to be exhibiting worrisome features or progression, we tend to operate on those patients. In the future, perhaps we will have this intermediate option where if we start seeing it head in the wrong direction, we could intervene with some of the alcohol or chemotherapeutic injections, but they're not quite ready for prime time yet. But someday in the future, we hope they will be.
And Randy asks, how often should we get MRIs if pancreatic cysts have been detected, especially since my mother passed from pancreatic cancer?
Yeah, important question. And a lot of those things depend upon your family history, as you mentioned, and the size of the cyst. Okay, so my recommendation for someone with a 5 millimeter cyst will be different than someone with a 2.5 centimeter cyst. Okay, and as you saw, there were a lot of boxes in those diagrams that I was showing you, and the reason is there's so many boxes is because based on size, there's different recommendations. So in short, the larger the cyst, the more often you look at it. Small cysts can usually be followed maybe every other year, whereas large cysts typically get to be evaluated. Very large cysts usually more 3 to 6 months, or 6 to 12 months. So it really depends a little bit on the exact size of the cyst and if it's growing.
And we had a number of questions about genetic predisposition to pancreatic cancer. Um, what's surveillance for people that have one, two, or three relatives that have passed from pancreatic cancer?
Yeah, so the it still appears that the vast majority of pancreas cancer, and of course most pancreas cancer is ductal adenocarcinoma, usually not arising from a cyst. So cysts can turn into ductal adenocarcinoma, but the majority of ductal adenocarcinomas don't arise from cysts. They're solid all the way. In those patients, it turns out that probably less than 10% are familial. Okay. There are, as many of you may know, there are now pancreas cancer gene profile panels that you can order and get. Okay. Most guidelines suggest that you need to have two affected individuals in your family to do that. Usually one of them should be a first degree relative. So dad, brother, something like that. Those are the kinds of relationships that we're looking, and usually you need more than one. So if you've only had one person, and in particular, if that person got it when they were sort of older in life, you probably don't need routine screening. Now, if you want, you could get a gene test in that setting. And if your genetic test comes back, let's say that your dad had pancreas cancer at 63, no one else does, but you decide to get a screening test with a genetic counselor, and it turns out that you have one of the genes turn positive. Depending on which one it is with that history, we may start you on a surveillance program, which we might not have without the genetic information. So that's one example of how it could change management. But usually, people with known risk factors on genetically, we will follow. So that's how we kind of make that decision. And of course, if you have two relatives meeting the criteria, we put you into a screening program as well.
Right. Let's go to the chat. George has asked, what is the difference among pancreatic cancer and pancreatic cyst and pancreatic plasmacytoma with bone and without bone?
Yeah, plasmacytoma is actually something that's really more related to things like myeloma that are really just metastatic to the pancreas. So the pancreas isn't the cause; it sort of just happens to be the destination point. And so you should almost view a plasmacytoma of the pancreas almost like a breast cancer met to the pancreas or a renal cell. It's not really from the pancreas; it just ended up landing there.
Okay, and Jill asked a couple questions. Please address IPMN not eligible for resection, had aborted Whipple and monitored now for 6 years, 6 centimeter cyst involved with hepatic artery, also have polysplenia, and what other preventive measures are being studied besides surgery for IPNNs?
Yeah, complicated story there for sure. I think that in general, we do, I think the main thing that we are looking at is cyst ablation right now. We don't know exactly why some cysts progress or not. If we had a better understanding of that, we could perhaps provide chemoprophylaxis, which certainly seems attractive. But we're a long ways from that. So I don't mean to mislead anyone. I don't think there's anything on the horizon. if you're saying, tell me what you're going to do outside, I think the main areas of where we're focusing on are being able to better predict which patients are going to either have a benign lesion where, as I showed you, I can tell you, don't worry, and you don't need any follow-up, or perhaps maybe stratify people into high and low risk based on molecular markers, fluid within the cyst. And that's a area ripe for research. And I think I was talking with Augie about some ideas that we have about maybe what we could do in the future to help use that cyst to predict how often we follow you, rather than just use the size, which is kind of what we do now. So those are areas, and then the other area that we're trying to really figure out is this cyst ablation and seeing if we could put an EUS needle in there, inject it, and then watch the cyst sort of involute. That's kind of where most of the work is being done right now.
Great. And it's 2:00. Do we have you for a few more moments?
Yes.
Okay, great. Claudia asks, which type of cysts are more prone to become pancreatic cancer?
The most common, the greatest risk is that main duct IPMN, where the river looked big. That has about a 40% risk. The side branch IPMN, most people think, they say 10 to 25. I think it's on the low end of that. And the MCN is 15. But if you want one answer, it's main duct or mixed type IPMN have the greatest risk for turning into cancer.
Great. Does being diagnosed recently with LADA cause more concern with 2 millimeter cysts?
I'm not sure what did they mean by LADA? I'm sorry.
LADA is in all caps. Mark, are you able to unmute? Okay.
Well, I think it was 3 millimeter cysts. I think that latent autoimmune diabetes, I think is, yeah, I think what the cyst was 3 millimeters. Is that what I heard?
Yes. I just unmuted. Yeah, I have 2 IPM and 1 non-IPN. One of the cysts I've had since 2012. It has not grown. The other 2 are brand new. We just saw on an MRI about 2 weeks ago.
Okay. Yeah, the good news.
They're side branch IPM. And
yeah. And so, I think that those sizes are very small. And the fact that your other cyst has been, over a long period of time stable suggests that this is something that you would probably watch, Mark. But I don't think there's, right now, you're a long ways from hitting any of those 3 high-risk criteria. And again, it's the nodule that's the one that's the most important. The cyst size is actually the weakest of those 3 big risk factors. And you're 1/10 of what you'd need to be to even hit 1. So I think you're in good shape with just surveillance. If you hadn't developed those 2 new ones that they'd seen, some of the guidelines would have said to stop following you. But this is kind of the reason a lot of us are a little bit nervous about one of those guidelines telling to stop at 5 years, is especially in young folks, is, how do you know that something else won't occur during the long remainder of their life? So at UCLA, we continue to still follow people, but perhaps at less frequent intervals once we know things are pretty slow growing.
in getting diagnosed with diabetes recently, they call it type 1.5. I mean, I was type 2 for 6 years, and then those conventional medicines were not working. And so then they diagnosed me with type 1.5, which is type 1, I guess, insulin dependent. You don't think that's correlated with having cysts on the pancreas?
I'm sorry, I missed just a part. Could you say that one more time?
Oh, do you think that being recently diagnosed with type 1 diabetes has anything to do with the cysts on the pancreas?
Yeah, one always wonders, there's the question is there some autoimmune process going on? We do know that in certain people, new onset diabetes can be associated with the development of pancreas cancer. That's certainly something that's been, I'm not saying that by any means that that's the issue with you. You've had good imaging, but we've seen people who don't have any imaging, for example, who do that. But with regards to subtle issues regarding to pancreatic cysts, I don't know that there's such a clear correlation, because these things do just pop up as you age. And as I showed you, that over time, especially with the fact that our imaging, our scanners are getting better and better, as well. So we catch smaller and smaller things. So we're doing more and more scans. We have better and better machines. And of course, our population is aging. So all of these things are causing the number of cysts to be seen to rise.
Thank you, doctor.
Steve asks, I was diagnosed with stage 4 acinar cell carcinoma in 2012 and now NED. In a CT MRI last October, an 8mm IPMN was discovered in the side branch of the tail. I'm a BRCA2 and get a CT MRI every 6 months. Because I already had a solid PACC tumor and Whipple surgery, should an endoscopic ultrasound be added as part of surveillance?
Yeah, good question. Certainly, so an acinar cell cancer has components of a neuroendocrine tumor as well as sort of standard ductal. Glad to hear there's no evidence of disease. We do know that people with IPMNs tend to also be at increased risk for pancreas cancer. So certainly surveillance makes sense. You also have BRCA2, which of course also adds to that risk. So absolutely that close surveillance is appropriate. The frequency, we generally tend to order MRIs to reduce long-term radiation exposure. That can be done, depending on the level of risk. I mean, it probably makes sense initially perhaps to do 6 months. Usually though, once we sort of get a period of stability for a year or two, we start extending the intervals to annually. Your question is specifically, should EUS be added as part of surveillance? And in general, we don't really look at EUS to try to catch 2mm cysts that were missed. We really try to look for EUS to get tissue from high-risk cysts that we're already thinking about surgery to see if they need to go right now, if they can be watched. So in short answer, I don't think you need an EUS right now, as long as you're going somewhere that can do a proper and a good quality MRI for you. I would be very comfortable with doing that.
And I see a lot of the questions in the chat, or some of them, if you will have the webinar on our website, because I think some of these questions can be answered by reviewing again. But if I can just ask 2 more, Dr. Muthusamy.
Sure.
Randy asked, what kind of genetic tests are available from the procedures you mentioned?
So from the procedures we do, they can run, there's actually some panels that they can do. There's a molecular testing panel that is available that looks for KRAS mutations, P53 mutations, other sorts of things in the fluid to kind of help. And it's actually a pink panel that they do within the cyst to try to give a prediction of whether it's mucinous or not. And then even within that, based on the level of the mutations, how aggressive it's like to be. So even if you know it's an IPMN, do I have a low risk IPMN that's going to stay stable for 5-10 years? Or is it chance that it's going to expand? Can you predict how it will behave? Even if that's really kind of the holy grail, because if we knew that accurately, we could tell one group of people, you know what, you don't need to worry because you're not going to really turn into cancer. Another group of people, we could tell you how often you need. And then for the high risk people, we could say, look, we can follow you for 10-15 years, but you're probably going to have some problems. And so let's just take care of this now. So that's where we hope to be someday, but we're not quite there yet. But if we can find the right genetic panels that are accurate enough, that would be a welcome addition. And but we're not quite there. But those are some of the tests that are available right now.
Okay, last question. You're a very busy man, so we appreciate it. In the Boston area, what hospital are you most comfortable working with? My brother Keith was treated at UCLA, had pancreatic cancer, and survived 7 years. Now my father, 86 years old, has 2 pancreatic cysts. One has grown 1 millimeter in 6 months. We're looking for best screening facility in Boston.
Well, you live in a place where there are a plethora of excellent hospitals. So fortunately, there are many, and I don't want to be necessarily accused of any bias here. I've worked with folks at several of the Harvard-affiliated hospitals, so Beth Israel Deaconess, Mass General, Brigham and Women's. That's not to say that there aren't other places, Leahy Clinic and others, Boston University, I'm sure, as well. But at a personal level, I've worked with some colleagues at the 3 main Harvard teaching hospitals. But I'm fairly comfortable in telling you that in a city of that size with that level of medical sophistication, I think you'll have plenty of excellent options.
Great. Any extra questions in the chat, I will ask Dr. Muthusamy to answer separately. I know you're quite busy, and thank everyone for attending today. Aggie?
Just a few words. First of all, this was an unbelievably wonderful presentation. You're very kind to us. Because I'm always on the positive side. The two words that I wrote down is common and surveillance. So with those two words, I can feel positive in suggesting treatments for patients or patients' families. And I do want to say hi to Randy, who, if you can see Randy, that's her beautiful artwork in the background. And Jane, we spoke on the phone, but it's very nice to see you. So Dr. Muthusamy, thank you so much for your long hour, longer than an hour.
Right.
Thank you very much.
A lot to cover. I appreciate everyone's time, and have a wonderful weekend, and I hope you enjoyed it. Thank you so much.
Thank you. Thank you.